this video, we'll be discussing about the gastric acid physiology, pathology, and the drugs. So let's get started. Here you can see this is obviously a stomach. So this sphincter present here is called the esophageal sphincter. It is a barrier between esophagus and stomach. Whereas this sphincter which is present here, it is called the pyloric sphincter, and it is a barrier between stomach and duodenum. Now, this stomach, it produces approximately 2.5 liter of gastric juice per day. 2.5 gastric juice per day. That means the lumen of stomach will be very acidic. The pH will be around 1 to 2. Now this acid means the hydrochloric acid. It helps in food digestion. Now let's understand the secretion of this acid. So let's zoom in into this stomach. Here you can see that this stomach, it has gastric pits, and there are some cells. There are actually many cells lining this stomach, like parietal cells, endocrine cells, chief cells, mucus cells, different cells. So for that, let's use this picture first. Here you can see this chief cell. The chief cell has a function to secrete pepsinogen. This pepsinogen is important. Why? Because it is important for the digestion of proteins. Whereas there are three main cells that are actually responsible for the secretion, not secretion, but the stimulation of hydrochloric acid. Why not secretion? Because secretion is only done by parietal cells. But the enterochromaffin cells and the G cells, they both stimulate parietal cells to release hydrochloric acid. In short, these parietal cells are the only cells that produce hydrochloric acid. But there are three cells that are responsible for stimulating the acid secretion. That is enterochromaffin cells, G cells, and the parietal cells. But there should be some cell to inhibit the secretion of hydrochloric acid, and that cell is actually D cell. So for that, let's get into the detail. Here you can see, suppose this is a parietal cell. These parietal cells have proton pumps. This proton pumps, what it will do? It will release hydrogen and chlorine in exchange of potassium. This is done by parietal cells only. Now, we also discussed that enterochromaffin cells and this G cells, they are also responsible for the stimulation of acid release. How? So suppose this is G cell. Okay. Now what it will do? It will release gastrin. And this gastrin, what it will do? This gastrin will go to the enterochromaffin cells and to the parietal cells and tell the parietal cell to release more and more hydrochloric acid. But this enterochromaffin cells, what it will do? This enterochromaffin cells, they will release histamine. And this histamine will go to H2 receptors which are present on the parietal cells. And this H2 receptor, it actually is histamine receptor. So what it will do? It will stimulate this proton pumps to release more and more hydrochloric acid. Now, other than this gastrin receptors are also present on the parietal cells. So these G cells, when G cells release gastrin, so this gastrin will go to this gastrin receptors as well as to this enterochromaffin cells. Enterochromaffin cells also have gastrin receptors. So what it will do? This G cells, it can stimulate parietal cells directly or enterochromaffin cells to release more and more histamine. Now, other than these receptors, there is also muscarinic receptors present. Now, what these muscarinic receptors will do? So, there is nerve supply coming, and that nerve is actually vagus nerve. Here in the stomach, vagus nerve supply will come and it will release acetylcholine, and this acetylcholine will bind to this muscarinic receptors on the parietal cells as well as on the enterochromaffin cells, and they will stimulate the production of more and more acid, that is HCl, from the parietal cells. Now, other than this, there is one more receptor present, that is prostaglandin receptor. This prostaglandin receptors, they are present at two sites. The first one is at the parietal cells, and the second one is at the mucous cells. Now, on the parietal cells, what it will do? So, before going directly to the this receptors, let's understand how the prostaglandins are secreted, released. So, we know arachidonic acid will release prostaglandin E2 and prostaglandin I2 in presence of COX, COX1 and COX2, that is cyclooxygenase 1 and cyclooxygenase 2. Now this prostaglandin, what it will do? This prostaglandin will go to parietal cells and will inhibit the release of hydrochloric acid. It will inhibit. But when this prostaglandin go and bind to the mucous cells, it will stimulate the process of release of more and more mucus. Whereas the D cells, they'll also inhibit what? So release of acid. So this D cells, it will release somatostatin, and this somatostatin, what it will do? It will inhibit parietal cells. And other than this somatostatin will also inhibit enterochromaffin cells and G cells. This was all about the physiology of acid secretion. Now, what if there is more and more acid secretion? It will lead to ulcers. So now let's start with the pathology now. Now, this peptic ulcers, what are peptic ulcers? It is actually eroded areas of the mucosa. Here you can see they are actually the eroded areas of the mucosa. And there are two types of ulcers. One present in the stomach and one in the duodenum. If it is in stomach, it will be gastric ulcers. And in duodenum, it is known as duodenal ulcers. The most common site for the gastric ulcers is the antrum, whereas for the duodenal ulcers, the most common site is the first portion of duodenum. The first portion of duodenum. Now, the main causes, there are two main causes. There are many causes, but two main causes. That is H. pylori infection and NSAIDs. They are the main causes. So let's understand the pathophysiology of this H. pylori infection first. So H. pylori infection, it can be in stomach and in duodenum. So let's start with stomach. What this H. pylori will do in stomach? It will release urease there. Now this urease, what it will do? It will convert urea into ammonia. Why ammonia? Because this ammonia will make the stomach medium more alkaline. And because of this, the bacteria will now survive in the gastric lumen. And once it survives, it will colonize and attach to the epithelial cells. And once it attaches, it will release cytotoxins. And these cytotoxins, they will disrupt the mucosal barrier and cause damage to the underlying cells, causing ulcers. This was about the pathophysiology of H. pylori infection in stomach. What it is doing? It is releasing urease. What urease will do? It will convert urea to ammonia. Now the stomach will become more alkaline. The lumen will become more alkaline. And because of that, the bacteria will now survive. Because bacteria can't survive in the acidic medium. So it needs a more alkaline medium. So it will survive. And after that, they will colonize and attach to the epithelial cells. There they will release cytotoxins, and after that they'll disrupt the mucosal barrier and damage the underlying cells, causing the ulcers. This was all about the stomach. Now in duodenum, what H. pylori will do? This H. pylori, it will inhibit the somatostatin. What was the normal function of somatostatin? Somatostatin was responsible for inhibiting parietal cells to release more and more hydrochloric acid. That means it will decrease hydrochloric acid. But we told here that it will inhibit stomatostatin. That means if stomatostatin is inhibited, the acid concentration in the duodenum will increase more and more, leading to more and more gastric secretion. There will be acidification. More and more acidification means it will lead to ulcers. Now what the NSAIDs use? So the NSAIDs, they'll simply inhibit cyclooxygenase 1 and cyclooxygenase 2. Now what cyclooxygenase was doing? So we know that from arachidonic acid we were getting prostaglandin in presence of cyclooxygenase. Now if this cyclooxygenase is inhibited, that means we won't get the prostaglandins. And what prostaglandin was doing? It was inhibited the acid release and activating the mucus cells to release more and more mucus. That means if the prostaglandin production is inhibited, there will be erosion of gastric mucosa leading to ulcers. This was about the pathology of ulcers. But other than ulcers, there can also be this GERD. Now what is GERD? It is gastric esophageal reflux disease. So what happens in a normal healthy stomach? This sphincter, it is closed, which won't allow the gastric juice to pass into the esophagus. But in GERD stomach, this sphincter is not closed properly, leading to a reflux of acid back into the esophagus. And the most common symptom in GERD is heartburn. It is one of the most common symptoms. And the complications can be Barrett's esophagus. Now, what is Barrett's esophagus? So, the normal esophagus, it has squamous epithelium. But in Barrett's esophagus, this esophagus has abnormal columnar mucosa. Now, this was all about the physiology and pathology. Let's start with the drugs now. So, there are three main drugs for acid suppression. The first one is H2 antagonist, the other one is PPIs, and the third one is antacids. So, let's go back to the physiology here. So, there was H2 receptor present on the parietal cells. Now, we know that parietal cells are the main cells which will release hydrochloric acid. That means if we want to stop the release of hydrochloric acid, we'll simply inhibit proton pumps. That will inhibit the whole supply of hydrochloric acid. But if we don't want to inhibit the whole supply, we can inhibit this H2 receptors. It will also stop the release of acid. Now, let's discuss one by one. So, starting with H2 receptor blockers. So, H2 is actually histamine. These H2 blockers are mainly used during peptic ulcer, mild GERD, and during gastritis. And the drugs that comes under this H2 blockers are cimetidine, formatidine, nizatidine, ranitidine. Now you may have noticed that it all ends with dine. So for that there is one very famous mnemonic, that is take H2 receptor blockers before you dine. Just think like table for two to remember H2, because it is not H1, it is H2. So just remember, H2 receptor blockers are taken before dinner. Before you eat something, you have to take H2 blockers. And every drug under this ends with dine. Now what's the mechanism? So we know the mechanism. It will reversibly block H2 receptors. And if it will block the H2 receptor, that means there will be less H plus secretion from parietal cells. Okay, the mechanism was really easy if you know the physiology. Now, obviously, it's drug. That means there will be some side effects. So, side effects of cimetidine. It is actually a potent inhibitor of P450. Next side effect is it is anti-androgenic effect. It has anti-androgenic effect. Other than this, it can also cross the blood-brain barrier and placenta. It can cross blood-brain barrier and also placenta. And there is one more adverse effect of this cimetidine. That is, it decreases the renal excretion of creatinine. Okay. Now, other H2 blockers are relatively free of these effects, but cimetidine is mostly, it has more adverse effects. Now, moving towards the proton pump inhibitors. Now, these proton pump inhibitors, they are mainly used during peptic ulcers, gastritis, GERD, Zollinger-Ellison syndrome, Zollinger-Ellison syndrome, and it is also used as prophylaxis during stress ulcers. So, stress ulcer is prophylaxis, and it is an important component of therapy for H. pylori. Okay. Now, the drugs that comes under it is omeprazole, lansoprazole, esomeprazole, pantoprazole, and dexlansoprazole. Now, all these drugs are ending with azole, so we can have a mnemonic like it blocks all the acid supply. It blocks all the acid supply. That means this azole, this azole ends with ol, and it blocks all the acid supply. So there is a rhyming all and ol. You can remember like this, and we know the mechanism here that it will irreversibly inhibit the H plus K plus ATPase in stomach parietal cells. It is irreversible. Now, the adverse effects. The adverse effects are it will increase the risk for infection. It also causes pneumonia, then acute interstitial nephritis, and vitamin B12 malabsorption. Now, other than this, there is one more adverse effect, and that is it will decrease serum magnesium calcium absorption. Okay, now this was all about PPIs, that is proton pump inhibitor. Now moving towards the antacids. Now these antacids, they are what they do. So they alters the gastric and urinary pH, and it delays gastric emptying. Now there are three types of antacids: the aluminum hydroxide, magnesium hydroxide, and calcium carbonate. Starting with aluminum hydroxide first. So it can cause constipation, hypophosphatemia, osteodystrophy, proximal muscle weakness, and seizures. Now, to remember this, there is a mnemonic. Here you can see aluminium means minimum. You can remember from this minimum amount of feces. That means constipation. And one more mnemonic is there: CHOPS. 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 The next one is magnesium hydroxide. So what it can cause? It can cause diarrhea, hyporeflexia, hypotension, and cardiac arrest. Now to remember this, simply remember Mg plus 2. That means must go to the bathroom. Must go to the bathroom. That means diarrhea. Now for the calcium carbonate, it's simple to remember because it will obviously cause hyperkalemia. And also one more thing, that it can sometimes cause rebound acid, more and more release of acid. Now the next drug is bismuth and sucralfate. Now what it will do? So it will bind to the ulcer base, providing physical protection and allowing carbonate secretion to re-establish pH gradient in the mucus layer. It is used for increased ulcer healing, traveler's diarrhea, and this bismuth, it is used in quadruple therapy for H. pylori. But this sucralfate, it requires acidic environment, and therefore it is never given with PPIs and H2 blockers. Now moving towards another drug, that is misoprostol. Now this misoprostol is actually prostaglandin analog. What it will do? It will simply increase the gastric mucus barrier. That means there will be less acid production. Now, if it is a prostaglandin inhibitor, prostaglandin analog, that means it can be used for the prevention of NSAIDs-induced peptic ulcers. Yeah, so it will be used for the prevention of NSAIDs-induced peptic ulcers. And there is one more use of this uh, misoprostol, that is, it is used for the induction of labor because it ripens the cervix. So it is used for induction of labor, and therefore it is contraindicated in pregnancy. And what are the adverse effects? So adverse effects are diarrhea and nausea. And one more thing is that it is contraindicated in pregnancy. Easy to remember. Next drug is octreotide. Now this octreotide, it is actually a somatostatin inhibitor. What it will do? It will inhibit gastrin, also the growth hormone, glucagon, insulin, CCK, secretin, and VIP. Other than somatostatin, it will also inhibit these all things. Now, it is used for acute variceal bleeds, acromegaly, VIPoma, and carcinoid tumors. Now, the adverse effects will be obviously nausea, cramps, steatorrhea, increased risk of cholelithiasis, and hypothyroidism. So this was all about today's video. I hope you liked the video. If you liked the video, do like, share and subscribe. Thank you.